Hello everyone, welcome to sqadia.com, and in this section we will talk about the treatment of endometrial cancer. In this we will talk about what are some pre-treatment evaluations done for the diagnosis and what are the options for the treatment, which can be surgical or adjuvant therapy, and what's the follow-up for the recurrence of the endometrial cancer. So pre-treatment evaluation is mainly a history and physical exam. So some lab tests done before the treatment is complete blood count, then different chemistry tests are done, and then liver tests are done, liver function test. And then CA-125 is the tumor marker used in the diagnosis in advanced disease. These are some lab tests done before the treatment. And then radiology, chest x-ray is performed, MRI, which is magnetic resonance imaging, ultrasound is done, and these tests usually they are not very reliable to assess the depth of the invasion of the tumor. So besides this, there are other tests depending on how the patient present or what are the symptoms. Those tests can be ordered accordingly. The treatment of the endometrial cancer, usually the main stay of the treatment is the surgery, followed by the adjuvant radiation or chemotherapy, again depending on the staging of the disease. Primary radiotherapy or chemotherapy and hormonal therapy can be used if there is any contraindication to surgery, or if the patient cannot have surgery, or if the tumor is too already extended or invaded or progressed, then usually surgery is not recommended in that case. So primary radiotherapy and primary chemotherapy is used when there is contraindication to surgery. Primary radiation therapy, about 3 to 5% of patients who cannot tolerate surgery, or if they have some contraindication to surgery, usually primary radiation therapy is used. Some common examples in which primary radiotherapy can be used if the patient is old, or if they are obese, or they have some other coexisting medical condition. The primary radiotherapy have very good control rate, survival and control rate. 5-year disease-specific survival rate with primary radiotherapy is about 87%. So it has a good control rate, about 87%, if depending on the staging again, and if the disease is limited or localized. Now, the hormone therapy which is used is mainly patients who desire fertility, who are young, and the patients in which the cancer is well differentiated. Usually, hormone therapy is recommended, and this the 75% patients usually respond to this hormone therapy. So it's a good choice of treatment if the patient requires, or if the patient wants fertility, then if the patient is young. The recurrence rate is about 25% in about 19-month period. The surgical treatment is usually the simple hysterectomy is done, in which the uterus is removed, but in case cervix is also involved, then radical hysterectomy is done, in which the removal of the cervix is also done. Then bilateral salpingo-oophorectomy is another surgical procedure in which both sides tubes and ovaries are removed. Pelvic washing is done. Then lymphadenectomy, which can be from pelvis or para-aortic. Para-aortic means around the aorta. Lymph nodes are removed that can prevent the spread to the distant areas if the involved lymph nodes are removed. And then omentum. Omentum is a peritoneal flap or hanging from the stomach that can sometimes be removed also. So this is omentectomy, removal of the omentum. Omentectomy here. This is the omentum. It's the flap hanging from the stomach. This can be removed, and this procedure is known as omentectomy. So these are some surgical options performed. Hysterectomy, just simple hysterectomy, which is just removal of the uterus. Radical hysterectomy, if cervix is also involved. Bilateral salpingo-oophorectomy. Lymphadenectomy, in which pelvic and para-aortic lymph nodes are removed, and then omentectomy, in which omentum is removed. Then lymph node metastasis or risk of lymph node metastasis in grade 1. We talked about grade 1 in which the cancerous cells well differentiated is grade 1. The lymph node metastasis is only 3%. In grade 2, which is moderately differentiated, the involvement of lymph node is 9%, and in grade 3 involvement is 18%. Myometrial invasion is usually superficial, is less than 5% involvement of lymph nodes, and if it's halfway involved, then 20% of the lymph nodes are involved. And if the cervix is involved besides uterus, then the involvement of lymph node is 15%. Lymphadenectomy is the procedure of removal of the lymph nodes. Routine lymphadenectomy usually is not recommended. Routine lymphadenectomy, it doesn't give any idea that routine lymphadenectomy has any beneficial effect on the survival of the patient. So again, depending on the stage, what stage is the cancer, lymphadenectomy should be performed. Otherwise, routine lymphadenectomy is not recommended. Laparoscopic staging. Laparoscopic staging of the uterine cancer is laparoscope is inserted inside the uterus through the small hole in the abdomen, and then find out the changes in the uterus, and then you can stage the cancer. So randomized trial of laparoscopy versus laparotomy for endometrial cancer staging. Laparoscopy is just insertion of the laparoscope and visualizing inside. Laparotomy is the opening of the abdomen and then examination or visual examination inside the abdomen. Laparoscopy is time shorter duration, length of stay is short, and it's a little cheaper also. So it's laparoscopic. Sometimes when the doctors use laparoscope to see inside, they finally decide then to progress to laparotomy, which is in 23% of the cases, it progressed to laparotomy. And usually short length of stay and longer operative time in laparoscopic group because they need more time to see inside as compared to laparotomy. When the abdomen is open completely, you can see, the doctor can see inside clearly. Usually the less time is required in that, but that requires longer hospital stay and anesthesia. So these two methods are used for staging the cancer, laparoscopy and laparotomy. Some prognostic factors in the endometrial or uterine cancer. Most common prognostic factor, as in any tumor, is the staging. Then other important prognostic factor is lymph node involvement is another important factor. If lymph nodes are involved, the more involved or more metastasized lymph nodes are, the poor is the prognosis. So prognostic factor compared with the 5-year survival rate or reduction in 5-year survival. If there is lymph node metastasis, the 5-year survival rate is decreased 40%. If the cancer type is papillary, serous, or clear cell, then 5-year survival rate is less than 40 to 60%. In high-grade endometrioid, it's 25%. In deep myometrial invasion, it's 30%. And if its tumor size is big enough that it covers the whole uterine cavity, then the survival rate is 30% less than 5 years. And if the 2 centimeter, if it's more than 2 centimeter, then it's 10%. If there is lymphovascular space invasion, then it's 20% less. And if there is just adnexal involvement, then it's 5%. Adnexia means surrounding, adnexal involvement, surrounding involvement. So depending on these factors, if they are present, the 5-year survival rate of the patient is decreased depending on what histological type is present and what's the involvement of the lymph nodes. Now, the adjuvant therapy and chemotherapy or radiation therapy used besides the surgery. So first, observation is important to find out how patient is responding. Then usually vaginal vault radiation is done, pelvic radiation, and then extended field in which we cover the para-aortic region and pelvic region. Then hormonal therapy is also used and chemotherapy. So these are all the adjuvant treatments which include radiation, chemotherapy and the hormonal therapy. The adjuvant therapy, besides the surgery, it reduced the risk of recurrence of the cancer. Usually there is no increase in the survival rate if we use adjuvant radiation therapy or not. Then vaginal brachytherapy. This is the localized therapy or radiation therapy applied to the vagina. Usually is done in the intermediate risk tumors. And external beam radiation therapy is used in high risk tumors. And so we have two: vaginal brachytherapy, which is only localized vaginal radiation therapy, is used in intermediate risk, and high risk usually have external beam radiation therapy. Follow-up is usually for first 2 years, extensive follow-up should be done every 3 to 4 months, and then after up to 5 years, usually 6 months. So first 2 years it's 3 to 4 months, and then after 2 years to 5 years is every 6 months. And each visit, usually pelvic exam is done, pap smear is done, and x-ray is usually done. The recurrence rate of endometrial cancer is about 50% within the 2 year of treatment. That's why its follow-up is very important in the first 2 years. If every 3 to 4 months is recommended because of high recurrence rate in the first 2 years of treatment. Most common site of recurrence is vagina or pelvic region. Most common site of extrapelvic metastasis is lung. That's why chest X-ray is recommended on each visit. Then there is isolated vaginal recurrence. If only vagina is involved, then they have good prognosis. Combined hormonal therapy is recommended, and then there is chemotherapy option if there is metastatic disease is present. So that was all about the treatment of the endometrial carcinoma. Thank you for watching sqadia.com.